Recording in progress.
A very good evening, everyone, respected faculty and distinguished delegates. I am Dr. Supriya Pol, currently working as a medical lead at Gennova. It is my absolute privilege to welcome you all to this stroke symposium that is dedicated to the AHA Stroke Guideline Update 2026. We are extremely fortunate to have with us today some of the most respected neurologists in this country, leaders who have shaped the stroke care and mentored generation of clinicians. I would also like to warmly welcome all our delegates who have joined us online today. Your presence and participation reaffirms our shared commitment to improving stroke outcomes for our patients. With that note, it is my absolute honor to introduce our today's distinguished faculty and the panel members. With that, for our today's faculty and coordinator, of course, there is no introduction needed to our course director, that is Ichapuria sir. We welcome you. Sir is the first neuro ICU and neuro intensive care of Pune. He has been a pioneer in the thrombolysis treatment of stroke. Sir has more than 300 public lectures and workshop on stroke. Sir is also a member of Indian Stroke Association and Organization. Sir is a founder of Pune Stroke Group, an ex-president of the Society of Neuroscience Pune, also an investigator, a principal investigator for many of the multinational stroke trials, and has awarded as a health icon by the Times of India Group. Sir, we welcome you.
Dr. Nestle, you are muted.
Yes. Thank you. So that
we
invite our first speaker, that is Dr. Padma Madam. She is a renowned neurologist and head of the Department of Neurology at AIIMS New Delhi.
Supriya, I'm ex-HOD and ex-chief. Now I'm no longer in AIIMS.
Yeah. Apologies from my end, ma'am. Ma'am is an ex-HOD at the neurology at AIIMS New Delhi. With over 30 years of service, ma'am has pioneered stroke care innovations like the Smart India app, Care, DAT, and Impetus. Ma'am is also a Padma Shri awardee by President of India in the year 2016. She holds fellowships from INSA, ASI, NAMS, and FRCB. She has received over 30 academic medals and led national task forces shaping the neuroscience policy. Her work blends clinical excellence and public health advocacy and transformative leadership in neurology. Ma'am, we welcome you. And ma'am is going to be the first speaker, and she's going to speak on AHA-ASA guideline update. With that note, we have our second speaker for tonight. We welcome you, sir, Dr. Subhash Kaul, sir. Sir is a highly skilled neurologist with more than 40 years of experience in the medical field. Sir has more than 105 publications to his name and has contributed to more than 20 book chapters. Sir has delivered more than 300 lectures, including orientation in last 25 years. He has also been an expert reviewer and member of editorial board for different journals. And sir has won number of accolades and honors on his name, namely State Teacher Award by Government of Telangana, past President, Indian Academy of Neurology, Indian Stroke Association and Andhra Pradesh Neurology Association, Jacob Javits Stroke Fellowship from the FAHA, and also Fellowship from FAN, that is FRCB. We welcome you, sir. And sir is going to speak us on our second topic for tonight, that is Tenective Place in India, a key insight. With that, it gives me an extreme honor to invite our two special panelists for tonight. First, being Dr. Kameshwar Prasad, sir. Sir has over more than 40 years of experience in neurology and national health leadership. Sir is also a pioneer in the evidence-based healthcare in India and a huge contributor to the Government of India program since 1997. Sir has a clinical expertise across stroke, dementia, epilepsy, Parkinsonian disease, multiple sclerosis, infection, and neuromuscular disorders. Sir is a pioneer in the stem cell therapy in stroke and multiple sclerosis in India, and he is a founding president at the Indian Stroke Society. Sir is also a member of key global bodies including WHO, World Health Organization, World Federation of Neurology, with more than 400 publications to his name. We welcome you, sir. With that, we have our tonight's last panelist, that is Dr. Vikram sir. Sir currently is a director and clinical lead interventional neurology program at NH Group India. Sir is governing council lead of neuroscience and is also heading the neurology NH Institute of Neuroscience. To name a few of sir's key achievements, sir is the first neurointerventionist to do a temporary endovascular bypass in stroke in India. Sir is also the first neurointerventionist to use the stent retriever in 6 years child in Asia. He has started a fellowship program in stroke and interventional neurology. Sir has a team who has done more than 8,500 neurointerventions procedure, and he has many publications, both international and national journals, and is also a reviewer for many of the national and international journals. Sir has expertise in neurointervention, namely stroke, aneurysm coiling, flow diverter stenting, carotid, and dural fistula embolism. With that, I would now hand over the session to Dr. Ichapuria, sir, to set the context for today's symposium. Over to you, sir.
Thank you for the very kind introduction. Today we have a galaxy of fantastic speakers, and each one is a star in the field of stroke neurology. What can I say? I don't think we can get a better panel than this. So also, now with these new guidelines, there has been a lot of activity in the stroke field, and many new interventions, new guidelines, how to treat, how to manage blood pressure, how to manage blood sugar, which patient to take. All that will be discussed very beautifully, I'm sure, by Dr. Padma, and she's going to talk to us today first on the new AHA guidelines 2026 for stroke. So may I request Dr. Padma to start her lecture?
Thank you, Dr. Ichapuria, and thank you, Gennova, for this opportunity to connect with you all. It's certainly an honor to be here. Will you be sharing, or shall I share the slides? And I can just share the slides too. You want me to do that?
Ma'am, you can share, and if you want me to share, I can also do that.
Just share it then.
Okay,
share
just
it,
give me a moment.
share it so that it becomes
yeah,
easy.
Just a moment.
So before we get on to the slides, I may just start adding that, that it is true, as Dr. Ichapuria had said, that the stroke momentum is so humongous, and it is such a rapidity of changes. And I must say that we are actually trying to put old wine into new bottles, because we are reinventing wheel at sometimes, because not so much in terms of thrombolysis or in a vascular thrombectomy, but certainly in stroke prevention, because we have the new molecules, we have new evidence coming in, not obviously as part of a guideline yet. Lot of movement across the factor 11A inhibitors, for example. And then we are, there are new stars on the screens, silastazole, things which have been there in the world market. But I think one thing, and I would certainly take this opportunity to share with you all when we come to the next slide. So the first slide, can I have the first slide? Yes. So when a guideline comes in, now this actually came in 6 years after the 2018 guidelines. We did have an update, but then it has taken almost 6 years to get into a guideline framework. And obviously a lot of literature, a lot of science which has gone into this. And all of us have actually gone through, in depth into this huge publication. It's been on WhatsApp, it's been on mails, and it's also been on hard copies. And it was very interesting. And some of it, you would skip, but they have actually listed down the science as it stands, and also the gaps they've highlighted, as it happens in any guideline. But I thought it was this far more clarity in the way they have put in, and a lot of effort which has gone into it. So next slide, please. So it actually encompasses the entire, the tapestry from recognition of stroke in the community to a triage, how an EMS system picks it up, and where they would go to a stroke-ready hospitals, the stroke maps, the wheels, and the framework of whether you can actually determine a large vessel occlusion so that you can bypass, the stroke readiness in terms of how ready they are, in terms of intravenous versus endovascular thrombectomy, and also the framework of what can you do, and the EMS system of the positioning of mobile stroke units, and also the guidelines of the blood pressure management and other ways of targeting the ischemic penumbra itself while the patient is being transported to the acute triage. So all these into the various the science that is available, the evidence that is available, and what can we put into guidelines, and what are the gray zones, and what could be the key takeaways, as well as the horizons where more work has to be done. So all this has been put in. So we, of course, what would be important to us in a developing world, and what would be immediately, what are the low hanging fruits for us, would be the thrombolytic choice and the eligibility and the expansion of where all this thrombolysis can be given. The shrinking of the contraindications as such, it was not just thinking out of the box. We are actually finding science to deal with this thinking out of the box. And more importantly, the endovascular thrombectomy, Vikram is here who can deliberate on this, and because he has a hands-on experience on this, as to bring into the ambit of who all can undergo the endovascular thrombectomy. Means, the cores are becoming larger. So you can have a larger core. You can shrink the aspect score. It's no longer 6 and 7. You're coming to almost 0 to 3. And then the nitty-gritty of the stroke unit guidelines. How much do you treat a blood sugar? How extensive should the blood sugar be lowered? And also definitive management of dysphagia. There is evidence now to go beyond just terms of swallowing reflex and you wait for time or a physiotherapy. You need some other gadgets to improve dysphagia. And a whole lot of guidelines now into the endovascular thrombectomy for pediatric population. And mind you, it's coming from 28 days to 18 years. It's a huge spectrum. Most of it is, around 6 years plus, but also some guidelines as to if there is an expertise intervention group, you also have 28 days to 6 years. And that I think is huge. And then, as I said before, the modification of thrombolysis contraindications. Next slide, please. So quickly, when you actually, this is a busy slide and I'm not getting into detail about any of those things, but the first, almost 6 were entirely dealing with the pediatric population, because the first time that the guidelines have framed in some kind of clarity and focus into the children with strokes. Because as these strokes are happening in younger and younger and younger individuals, that a stroke in young is no longer a rarity anymore across the world. It was never rare in India. It was never something which we all were not exposed to in reasonable proportions. But then in the world and in the pediatric population, in spite of, all the data we had about tips, and it's still those registries are going on, the intravenous thrombolysis part of it, is going on. But endovascular had remained a completely gray zone in terms of how to pick up a stroke in a child, what kind of guidelines and what kind of clinical criteria would you, require, what imaging criteria would you require. So there's more clarity in that, yes, you do this. And then also picking up a large vessel occlusion in pediatric population, irrespective of what the etiology is. Of course, we're not talking about mitochondrial strokes. We're not talking about metabolic strokes. But then when there is a stroke with a clot there in a large vessel, then we do have now guidelines to say that you can do an endovascular thrombectomy, provided you have enough expertise and also the wherewithals of an imaging criteria where you can pick them up. So that has been brought into the pediatric population. Next slide. And then you have this, the class of recommendations in terms of how you transport a patient. So earlier, it was always this, that in the stroke systems of care, when you pick up a stroke, then the EMS personnel is supposed to take to the nearest stroke-ready hospital. That I think still stays. I think it still stays, especially in our country. I think that's most important. But then what it does say is that, look, if your local community is not geared towards a rapid transfers between the, say, the primary to a place where you need to undergo an endovascular thrombectomy, then it made more sense that you took the patient directly to an endovascular thrombectomy or thrombectomy capable center, so that you are sort of not losing time in going through a nearest hospital and then getting referred to a place where you need to undergo an LVO, endovascular or mechanical thrombectomy. So they've said that go directly if the stroke systems of care are not allowing a smooth transfer of patients. But then there's also recommendation that you need to spruce up your systems of care and try to get in this inter-hospital transfers more smoothened, wrinkle-free, and rapid. So yes, that definitely is a gap that needs to be filled in across a lot of centers, and that is also true for the developing nations. And Vikram was part of the geospatial, the mapping system, and this has already been published. Shailja had done a wonderful job in that. And we've seen that how many of our patients actually could access even an IV thrombolysis center or a thrombectomy stroke center. And it is a dismal, the ratio is really dismal in terms of the optimal number of comprehensive stroke centers per say a million population. So those are gaps that which definitely need to be filled in. And there's more evidence here to say that, yes, you do it. Then the mobile stroke units have been given a lot of focus. And I think it's because of the publication of the science which came up from in the Australian place and also from the US trials, wherein in the communities where the, it's like Muhammad can't come to a mountain, so the mountain can't come to Muhammad, Muhammad is going to the mountain. So, that kind of a stuff that, the patient can't reach you, so you go and reach the patient. And yes, this is being tried out, is at least in the ICMR, sponsored thing, which was led by Dr. Jairaj Pandyan. And in the northeastern state, there were the 3 major centers which were attached to the 2 mobile stroke units was both positioned in Assam. Well, they have been important since I was also part of that. Basically, what it transpired is that it was helpful in setting up the stroke chain of survival, because it helped setting up a stroke unit. It helped in awareness of a stroke. It helped in people picking up a stroke. And also, it also helped in, say, the acute stroke care, an entire chain of survival. When you pick it up, you come, then, rapidly, then you're getting your blood pressure, your blood sugar, the stroke unit. I think that's the most important part of beyond all these glamorous interventions. And then also secondary stroke prevention and rehab. It helped put in those shape. So, and it also helped in picking up patients. So it did help, but I'm not very sure as to how much a mobile stroke unit would be hugely important in making a change. But then what is important practically is that if you're able to position in a mobile stroke unit, you do have an imaging facility. So you're able to distinguish a hemorrhage from an ischemic event. And in that, if you do have a wherewithal of push rather than infusion of a thrombolytic agent, it makes sense. So I think in this part of it, it does make sense. Probably it is a higher end fruit, but there seems to be a lot of focus on this. Then we have the organization integration of components, again, in terms of how the hospitals need to be geared up to be able to, meet the challenge of the stroke readiness as such, because of the enormity of the societal burden of stroke patients. So this has also been given a thrust and some classes of recommendation. But I think what we need is this blood pressure management. Seriously, this is, I think, one of those things which I really got flip-flop. And then, but it always have said that, again, it drives home the point that you need a pressure head. There was this thing about if you have a blood pressure to higher end, that you may bleed after an intervention. So there were 2 things here. Always, when you're not doing IVT, you're not doing EVT, the BP remained high. You needed a mean arterial pressure of 130 millimeters of mercury because you needed that pressure head. I don't think there was a much controversy there, except in acute situations like aortic dissection, that all of us are aware of. But when in an intravenous thrombolysis, and also EVT, when you had achieved nice recanalization, one thought that you had to drop in the blood pressure, and now you know that you should not do that. Don't go beyond 140 millimeters of mercury. So that has been given a lot of evidence that even in such patients who had recanalized, you need to have that pressure head. Don't go less than 140 millimeters of mercury. So that was one thing which got more evidence. And then we have the blood sugar management. Again, don't give IV insulin. Don't try to get it down to 80 milligrams. In fact, try to keep it between 140 to 180. So somehow the brain needs some glucose, although hyperglycemia is not required, but please keep the blood glucose at a certain level, keep the blood pressure at a certain level, which is definitely higher than what we initially thought of, to be able to get a better outcome. So that also has been given an evidence. Next slide, please. Right. And then came the thrombolysis. Oh, well, within the first 4.5 hours, I don't think we did perfusion imaging. I don't think anyone of that did that. We always, in our, I think the stroke management, it has always been, whether it is CT or MR based, it was parenchyma and vessel. I don't think we went beyond that, but that's what they also said, that look, don't do perfusion imaging. Within 4.5 hours, if it is the criteria, just go ahead and give IV thrombolysis. Now comes a choice of thrombolytic agent, and herein I want to bring in some points. I know Professor Subhash Paul will be still deliberating about this, but I think this is the moment, ladies and gentlemen, where as Indians, we can tell the world, we told you so. I think this is our moment. We always told you so. And I think the father of this moment is here with us, Professor Kameshwar Prasad. Now, I think he needs to be credited to the days when there was so much of skepticism and there was so much of, especially world over, they didn't believe this. And I think we were the first ones to show that this molecule works. And we were, in fact, I don't think the world actually recognizes. And out of all those, the science, I was trying to read through the entire evidence, there's very little mention of, say, the Indian, data. And we were the first ones to say, look, this works. And now the world comes around and says, yeah, it works. So therefore, the tenectic place, I think this story really needs to be shown to the universe. And we should, I'm so glad that the father of tenectic place movement in the world is here with us. And that's Professor Kameshwar Prasad. He was the one he was the one who got the approval. The country, India was the first country to approve this. And we've gone beyond all that. And now they're finding those guidelines. Oh, yes, now within 4.5 hours. Oh, we can give in for even for distal vessel occlusion. Now you have choice too. In fact, we're going to give tenectic place and say that this works better when there is a MEVO and a DEVO. You don't have to go and do EVT. You can give this. So I think we are finding a lot of evidence out here. And that's been said. Of course, it's 0.25 milligram per kilogram body weight, but there is some who say that the bleeds are less with, in fact, 0.2 rather than 0.25. Well, I'm not getting into it because that's not part of our guidelines. And then the extension of the time windows for IVT. Here, again, I think what is there is already known. It's just become more black and white, that 4.5 to 9 hours. And with picking up the ischemic penumbra, and how you pick up, there are various ways of it. And that I will leave it to Dr. Judith to discuss if there are any questions on that. But look at the way the EVT has sort of burgeoned. Look at the aspects, ladies and gentlemen. We've come to aspects 0 to 3 at sometimes, so large core, and irrespective of what the NIHS is, you still probably can go ahead and give some kind of a functional benefit in terms of if you have the wherewithal. The special recommendation is basilar artery thrombosis, where yes, within 24 hours, you should go and do the EVT. Next. And even the ages, less than 80 years, we've gone beyond that 60 years kind of stuff. So this is so the ages have, more inclusive. The cores have expanded, all depending upon how to pick up the salvageable tissue, the dying tissue, not dead tissue. And so also with this PC aspects and then the techniques. And then we come to this antiplatelet. Now here we do have great evidence that whenever there is, a minor event or a TIA with a high score, and where the evidence still says clopidogrel and aspirin for 21 days. I have not seen aspirin and ticagrelol here, but I think this field is changing, and maybe in the next guidelines we will get silastazole rather than the other grels here. For the evidence, and more importantly, the safety part of it. And I'm sure that you will get some evidence favoring the factor 11A inhibitors, especially the one that, what is that? It's got a peculiar, ansudixian or whatever that is. Then we have the anticoagulants, which are, again, I think this is, as such, there's not too much of a change out here. In a very minor event, now there is a definition of what the minor event may be. To me, a very minor event would be something like a hemisensory event or something, hemimotor, and a little loss of dexterity. To me, I think individually we should, I don't think it's really mild, but according to the guideline, they've all been put into mild, except the caveats of hemi-neglect and, the obviously aphasia or hemianopia. But these really mild is that you don't thrombolize and you give DAPT. In dysphagia, there is now evidence to say that you can use pharyngeal electrical stimulation, which will be beneficial to reduce dysphagia. So you're not waiting for just time to be able to help in dysphagia. Because dysphagia can cause microaspirations and aspiration. That's the biggest killer after stroke. And in brain swelling and medical management, there is something which says there is no benefit, not exactly harm, but no benefit with IV glibenclamide. Next slide. So largely, if you're juxtaposing one versus other, then you're looking at newer anti-thrombolytic, though this is not new for us, but this has got firm ground and it is in place, in black and white, and in your face. Said that, they've also actually talked about retiplase, they've talked about pro-urokinase, and they've given some evidence. They don't come into a guideline. They say these are the areas which need more science to come in before they come into any guideline. Largely, they are Chinese, and retiplase, especially there are some Chinese trials which say that their benefit is more than alteplase, but doesn't come into a guideline because there are a lot of limitations in the studies the way they're conducted. And in the threshold for IVT, the low NIHS is not exactly sine qua non to a minor deficit, but a minor deficit you're not. But the disabling deficit you treat regardless of NIHS, and that's a big thing. If you remember, actually, the original European stroke guidelines, NIHS is more than 25, don't give IVT. Now, that doesn't hold true anymore. The minor non-disabling, not recommended, DAPT. And don't do perfusion, don't waste time, obviously. And beyond 4.5 hours, you have all the ways of picking up where there is salvageable tissue, you do it. And I said before, EVT eligibility to large course and baseline occlusion is firmly grounded there in black and white. Pediatric strokes and the blood pressure, the glucose control, and any of those, added to IVT, let's give eptibiftide, and all those things are no longer recommended. But there is some evidence was emerging that when you do intravascular thrombectomy, and after that, you probably can still go ahead and give intraarterial thrombolytics. And that science is emerging, but has not come into a guideline yet. Direct to EVT center when you can. Mobile stroke units have for the first time got into a mention into a guideline, into some sort of a science. No longer they were never mentioned as it is. Next. I think that sort of sums up, I guess. Yes, now this is about it. I think I should leave this because we have Professor Call who will deliberate much more in this. And in children, may be safe, but I think we don't have a large experience to that. And again, when we talk about contraindications for IVT, those contraindications have shrunk and they've become much more black and white. So whether it's microbleeds, whether it is a previous stroke, whether it is large stroke, a very small stroke, all of them have got a more clarity. So compared to 1995, if you now put in the guidelines, the inclusions will become big. Contraindications will be actually much smaller if actually somebody actually puts into a table. Next, please. Next. Yeah, and I really think that when for us in India, again, Dr. Kaul will say that the push makes sense. It's actually no brainer. Whether you're looking at a door to needle time, or you're looking at a door in door out, the DDO times. Because even if you're trying to get an IVT and push the patient to the EVT, that's a door in door out, or a door to needle time in a triage, push makes more sense rather than an infusion. So seriously, that's a no-brainer. Next slide. 0.4 you don't give, that's a harm. Next slide. And this is actually this in fact has come into the guideline, and they've actually spelled out tenectic place and what for this kg, this much, and the maximum is 25 milligrams. Next, please. Next slide. So I think this is just would be a repetition of what we have already talked about. Next slide. Yeah, I think this is all a repetition. I think in fact, I've talked about that. Next slide, please. That's it. Thank you so much. And it'll be great to deliberate. And in fact, if there are questions which can come, it'll be good to, that would also set our brain cells thinking. Some of those questions would be the most important thing which will help us, focus on those gray areas. Thank you.
Wonderful, wonderful presentation, Padma.
Thank you, Dr. Padma, for mentioning my name. Thank you.
What, sir? You are the father of tenectic place. I think we should actually formally say that in the
Yes.
Seriously.
I've said it to Kameshwar so many times whenever we have met, but I think in an open forum, we must say thank you, Dr. Kameshwar Prasad, because I know how much opposition there was to tenecteplase, and now I think everyone is convinced, and the world is also convinced. And even the maker of alteplase is convinced that tenecteplase is better. And I know the trauma that he's gone through, and the fights which occurred, and all the things which happened. But that besides, Dr. Padma, I think you covered everything most beautifully. And I have one or two niggling questions, but I think we'll take that in the discussion. Because the discussion will be quite interesting. I'm sure. So we'll now go on to Dr. Subhash Kaul. Subhash.
Are my slides visible, Supriya?
Yeah,
Yes, sir.
But you are not visible.
Okay, no, I need not be visible. My sound should be audible.
Yes, but we want to see you also.
Okay, okay. Thank you very much for the opportunity, and thanks Gennova for doing all the research and making these slides. So I'll be just giving an overview of tenecteplase in India. Now, burden of stroke is increasing in India, and stroke is the 4th leading cause of death and the 5th leading cause of disability. And the prevalence in India, as opposed to the developed country, has increased by 41% from 1990 to 2019. And as per one incident study in 2016, every year, on that particular year, there were more than 1 million people of new stroke. Now, in India particularly, 20 to 25% of the strokes occur in patients with a previous stroke, which means that we are not that good at the secondary stroke prevention. And significant proportion of strokes occur in young people who are less than 65 years of age. And about 1/3 of the strokes occur in those less than 50 years of age. Now, all of us have been involved in stroke care in the last 2 decades, and we have been trying to create protocols and all. And I must say that there is some improvement. There's no doubt about it compared to what it was 20 years ago. There is improvement now. We have got infrastructures in almost all the states, and there is increased awareness among people through newspapers and through social media, through lectures. I have myself seen it in my own experience, and I'm sure all of you have seen, and all of us have worked towards it. In fact, to begin with, most of the thrombolytic movement in India started in the private sector. There was very minimal government institution like AIIMS and some other institute, but otherwise mostly it was driven by private sector, at least in South India. And there were limitations, and one of the major limitations was the cost of the drug. And therefore, it's in that context that the emergence of tenecteplase came as a very, very, big support to the thrombolysis movement in India. So therefore, now at this stage, we have some infrastructure, we have awareness, we have partnership with government. Government is responding to us, as you can see from here, that in almost many cities, you can see, these are the newspaper headlines, where there's this spoke and hub model is coming in Tamil Nadu, in Calcutta, in Karnataka, in Telangana. Definitely the sensitization of the government has taken place now. And in most of the government places, I think tenecteplase has been approved, and it's also economical, even for the individual patient and also for the government. Now, so I have to repeat it again, what Padma already said. I think one of the first persons who sensed this economics of tenecteplase was Dr. Kameshwar Prasad. And I also have been following Dr. Kameshwar Prasad in various lectures to pharmacoeconomics, whether it is GB syndrome and IVIG, or whether it is endarterectomy versus stenting, or whether it is tenecteplase. He is always with the economical, and he shows you with the evidence that the economical option sometimes may be better, and better in the larger perspective. So the advantage of tenecteplase versus alteplase, in addition to its economic advantage, is that it's ease of administration. You have to just give IV bolus. And this was more realized during COVID times, when we wanted to minimize the stay of the patient in the ICU. Longer half-life, 18 minutes compared to 3.5. So it stays for more time in the blood to do its work, and without causing significant bleeding, because it's clot specific. And it's more resistance to inhibitors and higher rates of recanalization, which has been shown in the Extend trial. And it's as safe, or even little safer, than alteplase. Now, let's look at the main clinical trial which brought this agent to the forefront. There have been some small trials before this also, but the main trial in India which brought it to the forefront was this one, which was subsequently published in American Journal of Cardiovascular Drugs. But even before publication, in fact, the trial was done a few years before it was published. And this a two-part study, part 1 and part 2. Part 1 was the dose-finding study, and part 2 was the confirmatory study. And at that time, the dose selected in India was 0.2 milligram. In fact, this is the time when the whole world was wondering what should be the dose. And there have been studies on 0.1 milligram, on 0.2, 0.5, on 0.2, on 0.4 also. And in India at that time, 0.2 was accepted at that time. And based on this study was done. And it was compared with the data which is already existing in the NINDS. And as you can see here, in this clinical trial, there was a statistically significant difference between the tenecteplase, 70% compared to 39%, who had a 0 to 1 MRS, which means functional independence. And same is true with the BI score, Barthel index, and the hemorrhage also was less in this. So this clearly showed the advantage of tenecteplase. Now, that's about the clinical trial. Now, what about the real-world data? So there was a establishment of this tenecteplase registry. It was called IRIS, Indian Registry in Ischemic Stroke with Tenecteplase. And this was also published in Journal of American Heart Association, which is a prestigious journal, in 2024. And this is, these days, this is almost a routine that after the clinical trial, the real-world registry is also set up to see that how it translates into the real world practice. And this registry also was set up to evaluate whether routine use of IV TNK after onset of stroke is safe. Safety was the first thing here because that's what we are worried about, the thrombolysis. And in fact, the benefit was thought to be the secondary endpoint. And it was an open label prospective multi-center non-randomized observational study. And these were the patients who were given tenecteplase, and then they were followed up for 3 months post thrombolysis. And the dose in this was 0.2 milligram per kg single IV bolus. Now, the outcome was, since safety was the main criteria in this registry, so the primary endpoint was the symptomatic ICH within 36 plus minus 6 hours. And the secondary outcome was the functional independence or the excellent outcome. And in this study, almost 1,000 odd patients were followed. And this was the real world study where you see 62 years was the median age, and the men predominant about 70%, and weight 60 to 73. So this is how the real patients are. The NIHS was, mild NIHS was in 35%, but 48% had a moderate NIHS and 16% was severe. And this is how we see the real stroke patients in the real world. And the risk factors were distributed again in the same proportion: hypertension, diabetes, smoking, so far. And what this study found, which was basically a registry, that 0.2 milligram per kg tenecteplase is safe in routine clinical practice, and the symptomatic ICH was 0.6%. And this is comparable to alteplase or a little better than alteplase. And efficacy also was seen. 56.3% patients showed reduction in NIHS more than 4 at day 7. So safety as well as efficacy was registry. And at 3 months also, this efficacy was maintained. And at 3 months, 75% of the patients had functional independence, which means 0 to 2. So even though there was a mild deficit, but they were functionally independent. And on the BI score, also 93% patients reported a good BI score. And if you look at this graph, it shows clearly that the advantage of giving this thrombolytic agent is distributed all across the different grades of stroke, different severity. And obviously in mild strokes, it's more. You can see that almost 80 to 90% are getting up to 2 MRS, which is quite good. And even in the moderate strokes also, same thing. And even in severe strokes also, if you can add this 15 plus 25 plus, about 40 to 50%, even in severe strokes also are achieving a relatively good outcome. So this real world data of about 1,000 patients established that IV thrombolysis with tenecteplase is safe and efficacious. So therefore, Indian guidelines are now, for the past several years, have now included this drug for emergency care among other drugs for emergency care. And the dose, actually initially the dose was 0.2 milligram per kg. But I have had discussions with Dr. Prasad, and I have heard Dr. Prasad in many meetings saying that he would prefer 0.25 milligrams per kg, because that is the dose internationally being given, even though the guidelines said 0.2. But now I checked the guideline myself today with the help of Priya in the evening, and we found that the guidelines indeed say that you can give 0.2 to 0.25. So we are okay in giving up to 0.25, but they are stressing, and they have stressed in guidelines that maximum dose should not exceed 20 milligrams. Now, this is a point worth discussion, and I think Dr. Prasad will probably tell us a story when he wrote to the UpToDate, and he told them that this drug should be included in the drugs which UpToDate had excluded. And they did say, and then they wrote the maximum dose is 90 milligrams. And then Dr. Prasad told them, no, it should not be 90, it should be 30. But here, the guidelines are saying 20 milligrams. And I think we'll hear from Dr. Prasad that, because, some of our patients are 100 kg, 110 kg, 120 kg. But as per the Indian guidelines, we are not supposed to exceed 20 milligrams. And now the shot in the arm comes last year with the FDA in March 2025 approved tenecteplase for treatment of acute ischemic stroke. For some reasons, we are very fond of FDA, compared. I mean, I have always wondered why we are so fond of FDA. Why don't we recognize Japanese Stroke Society or Korean, drug regulatory authorities or even British drug? We worry about FDA. So therefore, so we should be happy that FDA has approved it. It has nothing to do with Indian drug. It's an American organization, drug regulatory, but we respect it. So the FDA in March 2025 approved tenecteplase for treatment of acute ischemic stroke. And now Padma has today told us that it's not just FDA. Now it has come in the guidelines, and it gets as much of power of recommendation as alteplase, and that is a big advantage. So therefore, to summarize, I think tenecteplase has come a long way after about 7 or 8 years of struggle in this country, and finally, I'm repeating Padma's words. We put our trust in the drug with the help of Dr. Kamesha Prasad, because many of us were reluctant, myself included, that whether this will work or not. But Dr. Kamesha Prasad stood his ground, and I have myself seen some battles which have taken place, sometimes very embarrassing ones, in which many of the international faculty were very offended, but he didn't care. He stuck to his roots, and time has shown that he was correct. So thank you very much for the opportunity.
Thank you, Dr. Subhash Kaul, for a lovely overview on tenecteplase and tenectase. Dr. Supriya, shall we have the panel discussion?
Yes, sir. So moving ahead with the panel discussion, there are a couple of questions from the audience, sir. With permission, if I may ask.
Yeah, please.
So we have one question to Dr. Padma, madam. Ma'am, I'll read out the question. Is it true that the original molecule of tenecteplase and the molecule available in India are different, and hence Indian scenario may be different?
So yeah, it is so there is a biosimilar is what they say, but I won't know the exact difference in terms of the molecules as such, what amino acids are different or whatever, but it is a biosimilar in the sense that it is not manufactured by a foreign company and this is an Indian make. And I think it is a true story of make in India being a success story. So that way I would say yes, there's a difference, but it has been truly successful. Now your question is it that the molecule is different and therefore it is working better in an Indian scenario? Would that imply that we are genetically programmed to better respond to tenecteplase? See, these are not the questions that I'll be able to answer. But yes, the difference is that it is a biosimilar. That's what has been told. But as far as the Indian community, responding it very nicely is what is also being, duplicated for this molecule across the world. It is not just an Indian registry which has said that tenecteplase works. It is working everywhere. So I think the molecule works. I mean, this entity works.
Can I pitch in? Can I make
Yeah, Subhash.
Padma, if you
sorry. Go ahead.
Padma, if you remember, not a trial, but in AIMS, you did have a registry during the COVID times when these two drugs were compared, tenecteplase versus the alteplase, the biosimilar tenecteplase, and there was not much difference. And the second thing is this biosimilar concept is very much prevalent in oncology and rheumatology, and they are very well accepted as the original ones.
Yeah, I think it is an accepted pharmacological entity as such in the for the availability of and also the affordability of particular a molecule. I think across boards, as you said, in oncology, in rheumatology, in a lot of our monoclonal antibodies, we have biosimilars and that are being used. Sir, you want to come in, sir?
Yeah. Maybe I should tell them this biosimilar thing is being raised for last 5 years or more than that, because some of you who were in Ahmedabad, you will remember that is where I had, I can say, almost direct confrontation with foreign guests, because they were trying to uh, push the idea that tenecteplase use in India is misguided and unfounded and should not happen. So that is where I had to put my reasons why we think it is appropriate. But then they also raised this question that it is not, it is a biosimilar. So one should think about that. The point is that, as Dr. Kaul rightly said, there are a lot of biosimilar which we are using in India, because biosimilar is very less expensive. And as far as working is concerned, I had told in Ahmedabad also that, look here, cardiologists have been using this tenecteplase for years together, and more than 10,000 patients have been published by cardiologists who have used this biosimilar in heart attack, and nobody has ever complained that it works less or less effectively. So that is one point I said. Then, as far as molecule is concerned, that is the time we had argued. I don't remember now the exact chemistry, but I said there is molecular wise, it is not inferior to the molecule which innovator company has brought in. And the third thing I told them is that, do you know that ICMR, Indian Council of Medical Research, has started a project, and Dr. Padma will know, Balram Bhargav was doing that. That people go in motorcycle, and anybody who is having chest pain, they give this tenecteplase injection. And tenecteplase, which is made in India, is the one which has been recommended and is the one being used. And actually, Gennova will be able to clarify. I think they had donated that tenecteplase to do this project. So if cardiologists for almost now maybe more than 20 years they have been using, and they are happy with it, why is it that only in stroke they are bringing this question about whether it will work or not work? This is biosimilar. We have had experience of several years now, almost decades. So that biosimilar story I had countered I remember that the Canadian guest had raised this question. This is biosimilar, not necessarily working as well as the innovator compound. And these are the arguments I had given. So some of you who are there, you will remember that.
Sir, thank you for being putting Peter Schillinger in his place, because he said it is criminal that this product should be used. And now these days now, so we know, sir, what you did that day. And just to add, because I represent Gennova, we had just last year one Australian professor. He has been in this field for thrombolytics for 40 years. We had independently sent our samples to him, and he presented at INSC meeting. I don't know, some of you may have been there, and he showed it is as good as metylase. So, and it has been, as you have rightly pointed out, used since 2006. So it is essentially Alteplase was one product, commercial things, and which they have been doing, which we know. So they filed a legal suit and others. We don't want to go into that, but as a product, this is as good as innovator product. Recently, a trial was published from AIMS in JAMA Cardiology, which is, I think, 2 months back, and Professor Rohit Bhatia was also in part of it. It was in these prosthetic valve. They had compared tenecteplase, and it was our product. So
yeah,
there is no safety issue, no efficacy issue.
Yeah, remind me now. I have started forgetting. We approved tenecteplase in 2016 or 2017 for
2016, sir.
16, yes. So, because you have been asking to tell you the story about the approval, actually, when this data was presented, I was in that meeting, and it was being shared by a very renowned scientist and former Director General of ICMR. And he told me, I am very afraid today that I can make everybody agree, but not Dr. Kameswar Prasad, because, because I think he will he will disagree. So I said, sir, let me see all the evidence. And they had brought in the full file with all the papers which have been published outside abroad. But more importantly, I should tell you that Dr. Telangana, who was a senior resident in our unit or our department, she had presented a seminar which I had guided her. And that was very much in my mind. And I won't go into details, but we approved in 2016, right? And then, of course, I won't go through all the pains and debates and all the fights which went on for some years. But just to complete the story which Dr. Subhas Kaul was mentioning, that even in my own department, we had difficulty in convincing people to use it. So we said, I asked my residents, you see, who does it? Usually residents go there, they discuss with the consultant and they give thrombolysis. So it was all L-teplase. So I asked one day, why are you not using tenecteplase? They said, sir, we read up to date में तो अभी investigational drug लिखा है. मैंने कहा, oh, अच्छा, up to date. So that is how it came to my mind that I should get the up to date change. Then only my residents will change. So I wrote up to date that this is the evidence, this is the meta-analysis. Dr. Telangana had done a hard work completing all the data analysis. And we published in 2018, I think, 2018 or 19. Nobody quotes that meta-analysis. That was the first one to show that L-teplase and tenecteplase are similar in efficacy and safety. But after that, this stroke journal had another paper which was written from US. So that is what they started quoting more often. That normal, unusual thing. Our publications are quoted much less often in American or European guidelines. So not to worry about that. But up to date, after looking at our meta-analysis and our paper, changed the recommendation. And they said, and even today, it is the same sentence which holds. You know, they changed in 2019. And today also, if you read, it is the same sentence which stands till today. And that is, there is moderate to high grade evidence that that tenecteplase is similar in efficacy and safety and so on. And that was astonishing for some of my American colleagues that we could get up to date to change this. And that was, I think, a big win for our work. And our meta-analysis was quoted by up to date while changing the recommendations. So yes, I'm very happy that Dr. Subhas Kaul is speaking on tenecteplase, because we had a debate, he will remember, in I think one of the conferences in NCR organized by Sumit, where we had a very, let's say, interesting argument. And I said, in 5 years, all of you will talk the same language which I am doing. And that happened. So I'm very happy about that. So thank you, Dr. Subhas. Now you are on my side.
Yes.
Dr. Kamtekar, I want to make one point.
Yes.
Still in the insert, the dose is written as 0.2.
I should talk about the dose. You see, dose, from the very beginning, when we were making the stroke guidelines in 2019, that is where we first time wrote, 2026 Americans are writing. We wrote in 2019 that tenecteplase is alternative to L-teplase for thrombolysis. The dose point was discussed. As I told you, since my main source of, you can say, getting convinced was the trials done abroad, who used mostly 0.25 milligram per kg. So we wanted to write 0.25 milligram per kg in the guideline, but because it is a government guideline and DGHS was involved in this, so they said, no, because we have approved 0.2, so we have to write 0.2. That is why we wrote 0.2 to 0.25, I think, knowingly, because 0.2 has to be there, 0.25 has also to be there. 0.25 is the appropriate dose. I have been telling Gennova, you bring a vial with 25 milligram. And they are not listening to me. Maybe they will listen to our combined effort. They should bring, because 0.25 milligram per kg is the most widely investigated dose, and therefore we should perhaps move towards it. That is what, even up to date, when they said they wrote 90 milligram and 0.9 milligram per kg body weight, I wrote to them that please change it to 0.25 milligram per kg body weight with a maximum of 25 milligram. So that is the dose which they changed. Overnight they changed it, and that is the dose which is there.
No,
So
but
that
it
is
should be in the insert now.
no. You see, insert. We have been writing so many off-label, drugs. You know that everybody writes off-label. So you can use 0.25 milligram per kg as off-label. And since there is so much support from guidelines outside, no need to worry about that.
And so just to add one point, I was in one of the meetings in Australia. So there were neurologists from all across Asia Pacific. So I asked them specifically, do you weigh the patient? There was only neurologists from Japan who exactly weigh the patient. Other countries, Philippines, Australia, Taiwan, Korea, all of them were using estimated weights. So in effect, you may be doing 0.2, 0.25. We don't know. This is what these neurologists were telling me. Professor Park, Campbell was
That is
there. All
always
of
the
them were. They
case.
were asking this
That is always, it's always an estimated weight. You
Yes.
can't weigh the patient when he's got a stroke.
So we say this.
But at least, you can change it in the insert so that, it becomes uniform. Somewhere it's written 0.2, somewhere it's written 0.25. It creates confusion in some people.
They should get the label also changed.
Get it uniform. This is now the standard dose, and this is what has to be used. Finished. Don't have this ambiguity. Some people have this ambiguity, and they often ask me, and then they said, no, it's written there. Suppose we do this, but so let it be uniform.
Okay.
Sir, has
I agree with you. I agree.
approved up to 4.5 hours, sir? Because earlier approval was only up to 3 hours. Tenecteplase.
It is 4.5 hours. 4.5 hours.
It is 4.5 hours.
Yeah,
4.5 hours.
they got approval up
It
to
is got
4.5
approved.
hours.
Later,
Yeah.
it's got approved to 4.5
No,
hours.
but no one circulated that document, ma'am. We are asking them. No one circulated it.
Oh, okay, so I'll ask the team to circulate, because this is since 2023. It is up to 4.5 hours.
Okay.
And just to reiterate again to the whole team, sir, the quality-wise, it is as good as Metalase. There is no issue. I mean, whoever Dr. Supriya asked the question, we ensure from our side, because we have been making this since 2005 actually. So.
All right. I think even before we have formally begin the panel discussion, we have already had a very engaging and insightful exchange, around the Tenecteplase, which clearly reflects how dynamic this topic is. So I wish that let us take this discussion forward in a much more structured manner with all our expert panel. And I would request Dr. Ichapuria, sir, to please lead the discussion.
Yeah. Dr. Vikram, I wanted to ask you, now this aspect score of up to 3 we can give. So I am a little confused. So, after 6 hours, even if the aspect score is 3 and 4, we should do EVT. Do we need to do a perfusion scan, or it's no use?
Sir, I think now perfusion scan is out of guidelines, sir.
Yeah.
Except
so I want a clarification on that, because there is still a little bit of confusion.
Correct, sir.
Yeah.
So that's why we formed that rule, 3-6-24 rule. Correct. Aspect 3 and above, NHS means disabling stroke, which is 6 and above, up to 24 hours, we can do thrombectomy. So that was a rule which we published along with Dilip and Tudor.
It's called the Hewlett rule.
Yeah.
It's called Hewlett rule.
So we have modified it, sir. Modified it is, if aspect is less than 3, if within 6 hours, we can do thrombectomy. Even in posterior circulation stroke, aspect and 6 and above, PC aspect, and they say NHS 10, but 2B guidelines is even up to 6 NHS, we can do thrombectomy. So I think we have to simplify it. So because there are just imaging we need to do to rule out a bleed. So apart from that, we really don't know the real cause, sir.
Exactly.
So I think that's why, to simplify
So
stroke,
even if the aspect is low,
yeah,
and so therefore we think the core is large,
correct.
even then we should do EVT.
Correct.
Is that
So,
now the standard thing?
yeah. So no, that's why, sir, we need to subclassify large vessel occlusion according to core. Means we can't compare core less than 3 with
Not less than 3. 3 to 4, not less than 3.
sir, even less than 3 they have approved up to 6 hours.
Yeah, up to 6 hours, forget it. I'm talking of 6 to 24.
Yeah, 6 to 24, that's what, sir. When we have to compare, we can't compare 3, 4, 5 with above 6 and above. So they are a different group of patients. So we need to still push and do thrombectomies.
Yeah, no doubt about that. Now, what do you expect really, with with the aspect of 3 and 4? What do you really expect? Realistically, what results do you expect?
Sir, MRS score of around 30 to 40%.
MRS?
MRS 2 up to 30 to 40% is expected, sir. 0 to 2.
Okay. No, that's a little optimistic according to me. Padma, what do you think? Padma, Subhash?
Well, I think in the right hands, you would expect that. But I think a lot depends upon, even in the guidelines, there's a lot of emphasis, especially in the pediatric population, about the the expertise of the person who's doing it. So the guidelines are there, and we can have a hooded rule. But I'll be very comfortable if Vikram is doing it versus, someone who has a degree, but what is the expertise? So I think the generalizability and the skepticisms that you are showing, Dr. Chaporia, is basically depends upon who's doing that. You have a guideline, but I think a high volume and a high level of expertise is required in these special populations, as against a very, in a population which is far more, easy to do, and in a safer, because these are not the guys where there is a safety efficacy window which is very big. It's a tightrope walk. So I think in this, I think Vikram, you would agree with me on that. You do it well. You do a first pass. You do, there's so many things in that actually will have a good outcome. As compared to that, you pick up this and give it to any interventionist.
Yeah, I think this point is very important, Dr. Padma, that, the time taken for recanalization. If the time taken for recanalization and getting a good tiki is also very important. So if you are doing, say, second pass and third pass, it's not going to work. If you do if the time is time from groin puncture to recanalization, if it is short, if it is less than 30 minutes, then the response is up to 44%, 44. And if it is longer, then it drops to about 35.
Correct, sir. So what I'm saying is,
so I think, what is important, as Padma said, it has to be a high volume center. Now, how to get a high volume center? It's a chicken and egg situation, but expertise matters here. And how you do it matters, and how much time you take matters.
Sir,
Yes. Yes, Vikram.
Procedure credentializing has to happen. And unless we have high volume auto, so we are doing thrombectomy of 0.7%, sir. How to train people? So it is difficult.
Yes.
So I know that, but it is not always door to puncture to recanalization time. Even door to puncture time is also important.
Yes.
So
everything is important. Door to puncture, then puncture to recanalization is also. Then, managing BP during the procedure.
Correct.
So many things are important. Post-op management, sometimes the BP fluctuates wildly. There is cardiac arrhythmia. There is all these factors produce bad results. So, really, to have a good stroke unit and to have an interventionist who is done good number of cases and is become proficient in it, I think is very important. Now, this is a big gap that we have, and we need more Vikrams in the world and in India to do this. And if you can do it in 5 minutes, great, your results will be 2 and 3.
So
But
now
if you take 45 minutes, the result is going to be 5.
Sir, now door to cath lab trials.
Yeah. No, door to cath lab, groin to recan, all these things matter.
No, skipping the CT scan. Directly.
How to skip the CT scan?
Sir,
Yeah.
that is what I'm telling. See, door to cath lab. Now cath lab are equipped with CT, sir.
Okay.
Just
In that
rule out
way.
the bleed. Just
Yeah.
rule out bleed and do thrombectomy.
Yeah.
So that.
So Dr. Ichaporia, what about those less than 3 aspects?
Less than 3, I don't know how well they do.
You ask
Vikram, they don't
Vikram.
do so well.
Ask Vikram. Less than 3.
Yeah, let's Vikram say.
Yeah. No, that's what, sir, I told. Less than 3, up to 6 hours. If he is a young.
Yeah, then they do good.
Sir, that's what we always should compare different subtypes in even in mechanical thrombectomy. So the success of brain transplantation is 0. In that, if it is aspect is less than 3 and if 15% patient improve, that patient will make a huge difference, sir, for that patient. It is not for the trial.
Vikram,
young, I will always push, sir. And
Vikram,
when we do for large core, we should also tell them that he may require decompressive craniotomy.
Yeah.
If they don't agree for both, we should not do, sir.
Yeah. No, Vikram, we have a peculiar situation in our country of ICAD. At least, we've analyzed some of our cases. When the stroke is cardioembolic and you remove the clot, they do very well. But when there is ICAD, and even after you remove the clot, then these guys don't do so good. So what is your experience in this?
Sir, already rescue registry, we have published our data of ICAD with stroke. I think there is no difference, sir. The main thing is when we attempt 1 or 2 times, we should stop doing stent retriever, do angioplasty and put a stent, sir. In some of our cases, when we know, so how to identify ICAD versus embolic stroke. So usually if it is ICAD, they will have watershed territory infarct, they will have proximal occlusion like M1 stenosis, tapering versus distal M1. Yeah, so that will help us in identifying whether it is underlying ICAD or not. And if it is basilar, if it is vertebrobasilar junction, that goes more in favor of ICAD than distal basilar occlusion.
Yeah.
And during CT calcification, or if they have done previous scans, and if it is showing ICAD, then these patients, some of them, we have gone directly and put a stent. No need to do even thrombectomy. You can just aspirate, put a stent and come out. So if we do like that, then the outcome will be better.
So for our Indian situation, I think we need to modify our technique a little more.
Correct, sir.
And I think that comes with experience and doing more and more cases.
Correct.
So I think your point is well taken. Kameshwar, do you want to say something?
Yeah. I want to say one thing, that the Americans are, I don't know which country it started from, they make a mistake and then we blindly follow. So one example is LVO. That what is this large vessel occlusion? It is large arterial occlusion. It is LAO, not LVO. V is which will be both vein and artery. We know that. So why don't we start using correct word, large artery occlusion, LAO? Vikram, what is your point? Tell me.
We can do so.
Okay, that's a point. Yeah. So as Vikram has said, in our Indian situation, slightly different. I think the West hasn't appreciated this ICAD issue so much. We are facing it more. And, the time taken for recanalization also increases. Then you have to put in a stent. Then you have to give antiplatelet, tirofiban. So it becomes a little more complicated. And the more complicated it becomes, I think, at least in my experience, the results definitely decline. Padma,
Nasli,
yeah.
I also have a doubt. With your permission, can I ask it?
Yeah, of course.
You can also answer
No,
it.
you ask. You ask.
So what about these MIVUs and all, where we are not doing any mechanical thrombectomy, the medium vessels and even the distal vessels? What is our current take on that? Some people have recommended giving intra-arterial tenecteplase to them. So what is the current thing, Because there is no mention in the new guidelines also about that part of the artery, the medium and the distal large vessel.
Sir, there is no evidence for it, sir. The evidence is only for ICA, M1 and proximal M2 and basilar. These are the vessels we need to open mechanically. Remaining all vessels, there is no evidence, sir.
Yeah.
So
And
are you
the
giving
evidence does not show
intra-arterial?
benefit.
Are you giving
IV,
intra-arterial to them?
IV.
Huh?
IV.
No, not intra-arterial as we used to give once upon a time.
No,
Intra-arterial.
there is no evidence, sir. I think trials has to come. I think
Okay.
that's a very good point. I think for MIVOs and all, whether intra-arterial tenecteplase or actylase, we should do trial and do that, sir.
There is the trial which has come up, isn't it? The
That
one which is
post-thrombectomy, ma'am. That
No,
is
no,
post-thrombectomy.
beyond that, no, there is in the International Stroke Conference, the highlights which have just come out. So there is this one. Na? I'll just tell you about that. There is what is this? Tenecteplase. This is the distal occlusions, the TASTE trial, secondary analysis.
Okay.
I think,
So I think
what you're referring to, they found that tenecteplase is better than altiplase in M3 occlusion.
Correct.
Yeah, the
And
distal
in
vessel.
M2, they found both equal.
The distal vessel, the distal
M2.
artery occlusion.
M2 they found both equal for IV, and for M3 they found the tenecteplase better than altiplase. But Vikram, do you as a routine give intra-arterial after you remove the clot?
No, we don't practice that.
You don't. But there is data now to show that, these small vessels which are occluded and,
Correct.
to prevent what do you call failed recanalization, because, the distal vessels are not open. There are small clots floating around. So intra-arterial altiplase may help.
Correct, sir.
So you're not doing that as a routine.
No, we don't do, sir.
Yeah.
T2B, I think they have given recommendation, and it is 0.65 milligram tenecteplase, I think.
Yeah. So there is a role. There is a role for that. Now, the data is not robust, but there is a role for intra-arterial after you open the vessel.
Correct.
Yeah.
Nasli,
we could do that. I don't know.
Nasli, one of the differential diagnoses of ICAD is intracranial dissection. Now, I don't know how common that is, because that is thought to be a relative contraindication for IVTP, thrombolysis. Intracranial dissection. Do you see it? Do you see it?
Yeah.
And how to diagnose it as a differential diagnosis of ICAD?
Yeah.
Yeah, sir.
Yeah, I know. It's difficult.
It is very.
So just stent it, na? Just stent it.
But do you see it?
I haven't seen it.
So we have two cases, sir. So usually, if it is intracranial dissection, usually they are young, and ICAD is they will have risk factors like diabetes. So if a diabetic patient, usually it is ICAD. And if it is intracranial dissection, it is very rare. Usually, they will be also associated with subarachnoid hemorrhage. If there is a vessel occlusion,
may not be subarachnoid.
May not be, sir, but usually. So vessel wall imaging may help in differentiating.
But where is the time to do vessel
no,
wall
there's
imaging?
No. We are talking.
You're in a hurry.
Correct.
Time is brain.
Correct.
So there's no time to do all that.
Yeah.
Padma, this point, this electrical stimulation of the pharynx for this thing, that was a little new to me. I mean, I've not done it, but I think I shall start it after.
Yes.
No, it is, and
it
is coming in a guideline, and then so I think in that, the one thing which we definitely don't have a critical corpus right now are trained, specified, robust physiotherapy personnel in the country. We always talk about everything else. But yes, we do have physiotherapists as such, but the know-how and the knowledge is not huge. So I think this actually comes under the realm between the ENT and the physiotherapy department. Like, we do the whatever this videoscopic evaluation for a dysphagia, which is also done with the collaboration from the ENT department. So I think this pharyngeal electrical stimulation also, we need that know-how as to how to do it, and who will be the personnel who will be doing it.
Yeah,
Because
I think we should learn that,
point,
because it sounds very promising.
Very promising, but
especially now, say, with Wallenberg syndrome, sometimes, you have to put a Ryle's tube for weeks on end. So if you do this electrical stimulation and you can produce less of dysphagia or lesser time, it will be a great thing for them.
But so basically, we need to find personnel who will be able to do that.
Yeah,
But
we have to train
equipment and personnel.
They are not available. We have to train them, and we have to learn also how to do it.
Yes.
So
yes.
So it was a new point that you brought up, and I think it's very important that it's important for us. Subhash, this thing of 6 to 24 hours without LVO. We can give IVT 6 to 24 hours with distal vessel occlusion or not with LVO. What is your view on that?
As far as the guidelines are concerned, IVT, as far as guidelines are concerned, they are allowing only up to 9 hours. See, off-label, we can do it based on perfusion studies. But as far as the hard data and the guidelines is concerned, they say that you have to do perfusion studies, need not be rapid AI, but just perfusion studies. And if you show there's a penumbra with a ratio of 1.2, which means that there is a 20% more than the core, then you can give, but it should be less than 9 hours. And if
how comfortable are you with these perfusion maps? Are you comfortable?
No, perfusion study is important, but there is no advantage of the.
Are you comfortable doing it, and are you confident of
Yes. There's a learning curve. And we are comfortable. To begin with, there was a lot of teething problems, but eyeballing is as good as rapid AI. That part is for sure.
When we use rapid, we used it for some time, but I was not getting convinced somehow. And, we did a lot of wrong things also. So I got really scared doing it,
It excludes more patients than it includes.
Yeah.
If you look at carefully, their secondary outcomes, which was a shift analysis, which was developed because it will be a more sensitive outcome. One of the way we evaluate trial is whether secondary outcomes also support the primary outcome. Secondary outcomes in that trial don't support the primary outcome, and therefore, apart from being Chinese, which is, of course, Americans will never agree.
But Chinese are doing good work, huh?
Chinese are doing much better than Americans now. And we are hopeless.
Really hopeless.
We are nowhere. Yes. So it is still... there was another trial done in China only, Chelbis 2 or something, which didn't support the results of this stress 3 trial. So I think there are more trials needed. So up to 24 hours, there is not good ground to extend. But I will also say that, you see, before something comes in the guidelines, there is a lot of data which has to be available. But remember, when we did not have guidelines, we did not read guidelines, and guidelines did not exist, we still practiced medicine, right? So every question which you raise, for example, ICAD or M2 or M3 or intra-arterial. By the way, intra-arterial had a very good trial before even, I think, ICAS trial, which showed quite good result, but it was never replicated, and therefore it never came to light. But what I mean is that all these questions cannot be answered without waiting for more trials. But I think in a given case, as Dr. Vikram said, in a given case, you have to take a decision on the spot. only thing you have to do is you have to explain that we don't know, but we are going to do this. It may benefit in this way, but it has this risk. If you are willing to take the risk, we will go ahead and do it. So it should be very well explained and take, at least informal consent taken before you do something which is not in the guideline. In the guideline, if there is strong evidence, then not much discussion is required. You can just say that this is a guideline recommended treatment, and I would suggest that you should accept it. So that's the difference. So many questions will be there, each one requiring randomized trial. It will come in 50 years, but you have to practice today.
Yeah, Vikram?
Sir, one more thing. If it is a known case of ICAT, or if it is tandem ICS, IC occlusion, long segment, or if it is a lacunar stroke, I think we need to always compare. Tirofibam is one of the injection which we are not using, sir. I think
but
do a study of tirofibam versus tenecteplase in lacunar stroke and this IC occlusion and ICAT, sir. I think that is a wonderful drug.
Yeah, but you see, in these guidelines, it's just not made the cut.
Correct, sir. But
it's not made the cut. We have this problem with capsular warning syndrome. What to do with that? So tirofibam we like to use, or some. But it's not come in the guideline.
No, sir. What I'm telling is ICMR, if we have to do a study, because lacunar stroke, we reduce the BP to give tenecteplase. I think that is a problem. I think instead of that, whether tirofibam we can use in that situation, and if it is a ICAD or it is a ICA long segment stenosis, I think these conditions we need to do a trial on tirofibam versus tenecteplase.
Yeah, we need. So as Kameshwar said, we can't answer these. Correct. We don't know. We don't know. We think it will work, but we don't know whether it will work.
Correct.
Yeah.
Correct.
Dr. Supriya, shall we continue? Because this can go on into the night. Huh?
Yes, sir.
This can go on into the night.
Definitely, sir. I think after such an enriching discussion, as we come to close our today's enriching symposium, it's my privilege to propose the vote of thanks, sir.
We should have a discussion only for 2 hours.
Yes, sir.
Because, there are so many questions to ask. And so really, it was fascinating. Yes, Supriya.
So, sir, it's my privilege to propose the vote of thanks. And first and foremost, I would like to express our deepest gratitude to our esteemed faculty speaker, that is Dr. Padma Madam, for her clear and comprehensive overview of the HASA 2026 guideline update. A very thank you, ma'am. And second, to our Dr. Subhash Kaul, sir, for sharing such an invaluable insight on the role of tenecteplase in India and how it is shaping up. So thank you, sir. Thank you so much for that. And of course, our panelist, Dr. Kameshwar Prasad, sir, to share such a wonderful experience and insights right from the inception of tenecteplase, and our Dr. Vikram Hudet, sir, for such a thought-provoking and such a great panel discussion. And then, of course, not but last the least, a special word of thank you to Dr. Ichapuria, sir, for expertly steering the session, and that tied everything together so seamlessly. And without that, how can we fail to thank our audience who has joined us? Thank you, everyone who has joined us. And then I think that has elevated the quality of this discussion. With that, I hope the session has proved useful in our daily clinical practices and definitely sparks further thought and discussion beyond, today. So with that, I wish...
How much audience was there?
So I think there's an online thing which we have not seen. I think there's an online which they have sent out.
So there are 2 links. One is only for the faculty, and then there is another online for the other delegates, online delegates who has joined us.
So do you know the number?
371, sir.
Yeah.
How much?
371.
371, sir.
Oh, wow. That's good.
In total, as of 10 o'clock, 10:02 sharp, we have 391 registrations that have happened for the program.
Thank you. Thank you.
Thank you very much.
It's reached a large audience. So we are thankful to everyone.